Okay, now we're going to discuss various therapeutic procedures for managing respiratory failure. These procedures are fundamental components of care for patients with acute or chronic respiratory conditions. We're going to look at these treatments and how to appropriately administer them as healthcare professions. Remember, respiratory failure refers to a condition where the respiratory system fails in one or both of its main functions, oxygenation or carbon dioxide elimination. This failure can occur due to numerous reasons, including lung disorders, neuromuscular disorders, and chest wall abnormalities. In managing respiratory failure, these therapeutic procedures play a vital role. They're employed to aid respiration, ensuring that the patient's body is adequately oxygenated and that carbon dioxide levels are maintained within a normal range to avoid respiratory acidosis. We're going to specifically focus on three major procedures: intubation and mechanical ventilation, positive end expiratory pressure or PEEP, and kinetic therapy. Intubation and mechanical ventilation are key therapeutic procedures in managing respiratory failure. Intubation is the process of inserting an artificial airway known as an endotracheal tube into the trachea. This procedure is performed to ensure that the airway remains open and patent, facilitating the passage of air in and out of the lungs. Patients in respiratory failure often have difficulty maintaining an adequate airway or sufficient oxygenation on their own. Intubation supports these patients by establishing a secure pathway for ventilation. It's commonly performed in emergency situations, during surgery, or in intensive care settings when a patient's respiratory function is compromised. Mechanical ventilation refers to the use of a machine, a ventilator, to move air in and out of the lungs. This assists or replaces spontaneous breathing. In a nutshell, it's a life support treatment that helps the patient breathe when they cannot do that on their own. Mechanical ventilation plays a crucial role in managing both acute and chronic respiratory failure. It's used to deliver higher concentrations of oxygen into the lungs, remove carbon dioxide, and reduce the work of breathing for patients who are critically ill. This can improve oxygenation, reduce fatigue, and give the body a chance to heal. The two procedures go hand in hand. An endotracheal tube inserted during intubation serves as a conduit for mechanical ventilation, and this enables the ventilator to deliver breath directly into the patient's lungs. We're going to look at the important nursing actions that have to be taken before, during, and after the process of intubation and the initiation of mechanical ventilation, address some complications that might arise, and learn how to effectively manage them to provide optimal patient care. The period leading up to intubation is a critical window for ensuring patient safety and preparing for a successful procedure. As nurses, your actions can significantly influence the overall outcome. One of the key priorities pre intubation is to maximize the patient's oxygenation levels. Administer 100% oxygen to the patient. This is called pre-oxygenation, and it builds a reservoir of oxygen in the patient's lungs. And this reduces the risk of hypoxia during the intubation process. In some cases, the patient may require assistance with ventilation before the procedure. A manual resuscitation bag, also known as a bag valve mask, along with a face mask, can be employed to deliver positive pressure ventilation. This is particularly vital if the patient is in respiratory distress or exhibits reduced consciousness. Prepare for potential emergencies by ensuring that resuscitation equipment is readily available. This includes having a difficult airway cart, a suction machine, additional sizes of endotracheal tubes, laryngoscopes with different blade sizes, a supraglottic airway device, and emergency cricothyrotomy equipment. We might have to trach them. Effective communication is key during the pre-intubation period. The intubating team must understand their roles and be prepared for possible challenges. Any allergies, anatomical anomalies, or factors that might complicate the intubation should be communicated clearly to the team. And also continue to closely monitor the patient's vital signs, including the heart rate, respiratory rate, blood pressure, oxygen saturation, and level of consciousness. These signs can provide an early indication of patient deterioration. For conscious patients, explain the process of intubation, provide reassurance, and address any concerns or queries they may have. Encourage their cooperation with the process as far as possible. So the pre-intubation phase is all about effective preparation, careful patient assessment, and team coordination. And your actions can significantly impact the safety and success of the intubation process. Once the intubation is successfully completed, your role as a nurse transitions to providing post-intubation care. These actions are critical to ensure the patient's safety, confirm correct placement of the tube, and monitor for potential complications. Immediately post-intubation, the correct placement of the endotracheal tube is paramount. Assess end-tidal carbon dioxide (CO2) levels using a capnograph or colorimetric device. A positive reading indicates the tube is in the trachea. Bilateral lung sounds should be auscultated to confirm that the tube hasn't been inserted into one of the main bronchi, which would cause one lung to be ventilated more than the other. Also observe for symmetrical chest movement, another indication of proper tube placement. As soon as possible, a chest x-ray should be obtained to confirm the endotracheal tube's position within the trachea and that it is not in the esophagus. The tube should be located approximately 2 to 5 centimeters above the carina. Once the placement of the tube is confirmed, it should be properly secured according to your facility's guidelines. This is to prevent accidental dislodgement of the tube, which can lead to severe complications. Monitor the balloon cuff on the endotracheal tube for air leaks periodically. The cuff is inflated to create a seal against the tracheal wall, preventing air leaks and aspiration. Use a minimum occlusive volume or minimum occlusive pressure technique to ensure that the cuff is inflated adequately but not excessively, because that can cause tracheal injury. Continuously monitor vital signs, ECG, and oxygen saturation. Also be vigilant for signs of patient discomfort or distress, indications of developing complications such as changes in lung sounds and reductions in oxygen saturation. Depending on the patient's condition, sedation may be needed post-intubation to alleviate discomfort and anxiety and to ensure patient ventilator synchrony. Remember that the needs for sedation and analgesia should be continually reevaluated. Post-intubation nursing care is all about monitoring, rapid recognition of and response to complications, and ensuring patient comfort. Now, intubation and mechanical ventilation are significant interventions, and they often involve a lot of anxiety and stress for patients. As a nurse, an essential part of your role is to educate and reassure the patient and their family about these procedures. Start by explaining to the patient that while the endotracheal tube is in place, speaking will not be possible. This can be frightening, so it's crucial to reassure them that this is a temporary situation and there are alternative communication methods. Introduce and discuss different communication methods available, such as writing on a notepad, using a letterboard or electronic device, or even nonverbal cues like nodding or blinking. Ensure the patient that their needs will still be understood and met. Explain the procedure in simple, easy to understand language. Tell them about why we intubate and mechanically ventilate. Remind them that it's a life-saving measure designed to help them breathe and supply enough oxygen to their body. Educate them about what they might feel during the process. The presence of the tube might be uncomfortable. They might feel an urge to cough. Assure them that medication will be provided for sedation and comfort. Discuss the use of sedation during intubation and ventilation. Make sure they understand that sedation is not only for their comfort, also to improve the efficiency of the mechanical ventilation by promoting synchrony with the ventilator. Let them know they will be continuously monitored, and any necessary adjustments to the ventilator settings will be made to ensure their comfort and their safety. Encourage the patient and their family to ask questions and express any concerns they might have. The aim is to create an environment of trust and openness, which can significantly impact the patient's overall experience and outcomes during mechanical ventilation. Positive end expiratory pressure, or PEEP, is a therapeutic intervention used primarily in mechanically ventilated patients. It's an advanced ventilator strategy that can be crucial for patients with respiratory failure, including conditions like ARDS or severe pneumonia. In the simplest terms, PEEP is the pressure in the lungs, the alveolar pressure, above atmospheric pressure that exists at the end of expiration, at the end of breathing out. So essentially, PEEP prevents the alveoli, those little air sacs in the lungs that look like grapes, from collapsing by maintaining a level of pressure. If we didn't have PEEP, when we would breathe out, those little sacs would just collapse, making it really hard to breathe in. So the goal of PEEP is twofold. It keeps the alveoli expanded, and this improves the surface area for gas exchange. And by keeping them open, it also helps to evenly distribute the ventilated air, reducing the risk of alveolar damage due to repeated opening and closing. PEEP is typically applied as a setting on the ventilator. The level of PEEP is generally set by the respiratory therapist or the attending physician based on the patient's oxygenation status and lung compliance. It's a balance. While higher levels of PEEP can improve oxygenation, they can also lead to overdistension of the lungs and subsequent lung injury. As nurses, it's vital to closely monitor patients who are receiving PEEP for potential complications. This can include reduced cardiac output, increased intracranial pressure, and pneumothorax. These will be covered in more depth later. Remember, PEEP is a critical tool in managing patients with severe respiratory failure. It can significantly improve oxygenation and lung mechanics when used appropriately. As we covered in the previous slide, positive end expiratory pressure, or PEEP, is an important strategy in managing patients on mechanical ventilation. The main role is to keep the alveoli, those tiny air sacs in the lungs, open at the end of expiration. This is important because it helps to maintain a steady surface area for gas exchange between the alveoli and the blood vessels surrounding them. One of the primary benefits is improved oxygenation. By maintaining open alveoli, PEEP ensures a more efficient exchange of oxygen and carbon dioxide. This can be essential for patients with respiratory failure whose lungs are compromised. PEEP also plays a role in what we call alveolar recruitment. In certain lung diseases, some of the alveoli might be collapsed or filled with fluid, and this makes them unavailable for gas exchange. By keeping the pressure up, PEEP can help to reopen these alveoli or recruit them back into action. By preventing the repetitive opening and closing of the alveoli, PEEP can help to reduce ventilator-associated lung injury. This type of injury can occur when areas of the lung are subjected to high levels of stress and strain due to the ventilatory process. So, the use of PEEP has several benefits for patients experiencing respiratory failure. It improves oxygenation, recruits more alveoli for better ventilation, and reduces potential lung injury associated with mechanical ventilation. Now that we've learned about mechanical ventilation and the role of PEEP, let's look at a completely different therapy that complements them and can be crucial for patients with respiratory failure, and that is kinetic therapy. Kinetic therapy involves using specialized beds that continuously rotate or oscillate to shift the patient's position. This isn't just about comfort, it's a targeted therapeutic approach with a solid clinical rationale. Why would we rotate patients? Well, when they remain in one position for too long, not only is it bad for their skin and causes pressure ulcers, the dependent parts of their lungs, the parts that are lowermost due to gravity, may start to collapse or fill with fluid. This collapse, or atelectasis, can reduce the lung's ability to oxygenate the blood. Kinetic therapy aims to prevent atelectasis by continuously changing the patient's position. It uses gravity to help clear secretions from the lungs and distribute air more evenly throughout the lungs. This improves oxygenation and may reduce the risk of pneumonia. Kinetic therapy comes in different forms: continuous lateral rotational therapy, or CLRT, where the bed oscillates side to side; prone positioning, where the patient lies on their stomach for part of the day; and vibration or percussion therapies, which gently shake the chest to dislodge secretions. Kinetic therapy is another piece of the main puzzle in managing respiratory failure. By improving lung mechanics and helping to prevent complications like atelectasis and pneumonia, kinetic therapy can significantly contribute to a patient's recovery process. Implementing kinetic therapy effectively requires thoughtful nursing care. We're not just going to put the patient on a rotating bed and leave them alone. We have to monitor, we're going to intervene, and we're going to adjust the therapy based on the patient's individual response. When starting kinetic therapy, we should begin slowly and gradually increase the degree of rotation. This allows us to observe the patient's tolerance to the procedure. It's not just about the patient's comfort, although that's crucial. It's also about ensuring that the movement doesn't cause undue stress or exacerbate the patient's condition. During kinetic therapy, we have to continuously monitor the patient's vital signs, including their ECG, their oxygen saturation, their breath sounds, and their blood pressure. Changes in any of these may indicate the patient is not tolerating the procedure well, or that the therapy is exacerbating their respiratory failure. Their response to the therapy is what we're looking for. If they become distressed during rotation, we have to stop it immediately. This includes emotional distress and physical discomfort, as well as any changes in vital signs. And kinetic therapy involves a lot of movement. This can prevent skin breakdown, but it can also increase skin breakdown. So we need to be vigilant about providing routine skin care to prevent pressure ulcers and maintain the integrity of the patient's skin. Depending on their condition and their response to kinetic therapy, sedation may be required. Sedation decisions should always be made in collaboration with the healthcare team, considering the patient's overall health, their level of discomfort, and potential risks and benefits. Like all aspects of respiratory failure management, kinetic therapy is not a one-size-fits-all intervention. We have to tailor our nursing actions to the needs and responses of each individual patient so they get maximum benefit with minimum risk. So, we've covered a lot of ground today. We've talked about various therapeutic procedures for managing respiratory failure, from intubation and mechanical ventilation to positive and expiratory pressure and kinetic therapy. And we've seen how each plays a critical role in managing this complex condition. In each of these therapeutic procedures, the role of nurses is crucial. We are the ones who are directly monitoring patients, managing therapies, and acting promptly when complications arise. These interventions require more than just medical knowledge. They require astute observation, prompt decision making, and meticulous care. And don't forget the importance of client education, whether it's explaining why speaking won't be possible with an endotracheal tube in place or ensuring that they understand the reasons behind their therapies. Our role as educators is a critical part of our nursing responsibilities. Dealing with respiratory failure is a significant challenge, but with proper care and management, we can make huge differences in our patients' outcomes. By understanding these therapies and employing effective nursing interventions, we are best positioned to provide high quality care to our patients.